Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. Many experts can explain Ebola, but very few can explain what it means to survive it and watch the world repeat some of the very same patterns a decade later. Today, Stephanie Desmon talks to Dr. Craig Spencer, an emergency room physician at Brown University who contracted Ebola while working in Guinea in 2014, and brings a unique perspective of what he sees happening during the current outbreak in the Democratic Republic of Congo. Let's listen. Craig Spencer, thank you for joining me.
Thank you for having me on. I've listened for a long time, so it's an honor to be part of this.
So you lived through the 2014 Ebola epidemic as both a physician and a patient. So when you look at the current outbreak, what's the first thing you notice that most people might miss?
I think the first thing I noticed when this was first declared, just about 3 weeks ago, is the initial size of this. And maybe people didn't really raise their eyebrows at, over 200 cases on day one, particularly over the past few years when maybe we've been getting used to seeing hundreds or thousands of cases of things like COVID and that being a normal. But over 200 cases on day one of an Ebola outbreak is really, really concerning for a whole host of reasons. One, that it means that it was detected really late, so it's had a lot of opportunities to spread. And two, most Ebola outbreaks end before they're that big, let alone start at that size. And so I was particularly concerned within the first few minutes of hearing about this, and became even more concerned when I heard that there were more cases hundreds of kilometers away in a whole different country.
What does that tell us?
Initially, what that suggested to me is that, again, this had been spreading for a lot longer than the assumption was. Of kind of official accounts in the middle of May said that the index case was at the end of April and was a healthcare worker. But anyone that really knows kind of Ebola and Ebola transmission knows that a healthcare worker is not usually the first case. They are infected by the first case or other cases. And so we knew that this was going on a lot longer. To get to over 200 cases on day one means that this has likely been months, but it also means that there's been pretty diverse spread. And we saw that pretty quickly when the cases were reported across the region. And we had cases kind of all the way up from Butembo in the north down to Bukavu, or right around Bukavu, much further south. And for anyone that's worked in Eastern Congo, you know that to get from Butembo to Bukavu, even if it doesn't look so far on a map, can be, a multi-day process given the state of the roads, the need to get on a boat, but to get from, kind of Goma in the north side of Lake Kivu to Bukavu in the south. So that to me said that there had already been for quite some time some transmission, but that there had been multiple flames and clusters that had popped up. And the big concern was whether those would take off and become bigger outbreaks themselves.
So as someone who's experienced this firsthand, you call Ebola a disease of compassion. Can you explain?
Ebola is a disease of compassion because it infects the people who stay, or the people who stay behind to care. I don't particularly have any concerns for the average American, or really all Americans, about Ebola, because the instances in which you're going to be close to either a corpse that is highly transmissible or even someone who's remarkably sick is remarkably low. Because the people who are going to be close to those that are at their worst and at their most contagious are family members. So think of wives or parents or loved ones who are going to be providing care to a family member who's really sick, and know that they can't step away, even if they know that there's an incredible risk. Imagine having one of your own loved ones with something scary and deadly, but seeing them struggle and seeing them suffer. We would all undoubtedly find a way to step in and help in any way that we can. And then the other is, of course, healthcare workers who we know all around the world will show up day after day. And healthcare workers are at particular risk in places like Eastern Congo, not just because of this Ebola outbreak, but because they may not have access to the personal protective equipment that we have in our high-quality biocontainment facilities here in the U.S. And many don't even have access to some of the more basic personal protective equipment that we just take for granted, including things like gloves or maybe even running water. And so without those and without those tools, but with kind of the professional duty that many of us feel, a lot of healthcare workers will show up, will unfortunately be exposed, and a lot will be infected. And we've seen in previous outbreaks, including the outbreak a decade ago in West Africa, that somewhere between 6 to 8% of healthcare providers can be infected and can end up dying. And that is massive, not just because every one of those lives is important, but because when you think about the fact, the institution or the hospital where I was treated for Ebola in New York City had on staff probably around the same number of physicians as existed in Guinea, Liberia, and Sierra Leone combined at the outset of the 2014 Ebola outbreak.
So from what I'm reading also, it's a different experience in one of these treatment centers. Like we imagine a hospital setting and where the patient is fed and the patient is cared for by the staff. That's not what we see on the ground in these situations, is it?
Usually not, particularly at the beginning. This is, for lack of a better term, I'm an ER doctor, and this is brute triage. And the initial goal always has to be, step one is keeping your staff safe. Because if you don't, they'll get infected. They'll be taken out by this disease. So step one is making sure your staff are safe. And so we're just now seeing the personal protective equipment arrive. I have concerns that even though the PPE is there, you need to know how to use it well. And that requires training and supplies like chlorine and people to walk you through that process. So I do still worry that even once we get things like Tyvek suits and masks, et cetera, on the ground, there'll still be a delay in making sure they're used correctly. But there's also the brute triage of trying to get people who are infected out of the community to separate the virus from those communities and continue transmission. That requires a lot of work to convince people that there's value in coming to a treatment center. It's a lot easier when we have something to offer, like a treatment or maybe even a vaccine for family members. But in this scenario, we don't have any approved treatments. We don't have any vaccines that we know will be effective here. And that makes that bit about getting folks to trust treatment centers and to come into them a lot harder. And if we have people that are in treatment centers, I recall taking care of patients who, said at the outset, I don't think Ebola is real. But a few weeks later, after they survived themselves and saw the care that we were able to provide in treatment centers, left and wanted to be evangelists for not only just the fact that Ebola was a real disease, but that the treatment centers can, even if they're providing basic supportive care, can save lives and can have an impact.
So you talked about the reluctance that you find on the ground sometimes to this type of treatment. Help people understand these reactions, because I've seen news about the burning of treatment centers, and I don't understand sort of what's behind that, and I imagine you would have an idea.
I do, and quite frankly, I think it's fascinating and a bit astounding how a lot of our media kind of pathologizes what is an understandable reaction to in for communities who don't trust health institutions. This is a place where you have no reason to trust the government. You have no reason to trust health institutions. The government is like 1,700 kilometers away, and this is a place where, from town to town, you may have a different militia that's responsible for your safety. This is a place where healthcare facilities, if they're even open at all, may or may not have a provider and may not have the medications that you need. I think this is also particularly important because over the last year, there has been some research to show that not only the violence, but the violence plus the lack of USAID support that's been pulled back has resulted in a dramatic increase of hundreds of thousands of deaths, more than one would be expected at baseline. So it's no surprise to me that communities here are mistrustful of outsiders that are coming in. Imagine that you had a bunch of problems in your own community and a bunch of people came from the outside with funding and support and an urgency to tackle something that you, quite frankly, don't see as all that important. Imagine where over the last year, hundreds of thousands of more people in your part of the world die from preventable diseases like diarrhea or malaria, and there doesn't seem to be any concern. But overnight, a bunch of people come in with a bunch of resources, with big trucks, with guns, with messages that seem like beyond despair to say that you need to do everything we say and change your life for this disease that most people, quite frankly, won't see. And I think that the disconnect between the videos you see on CNN and in kind of Western media right now that show this catastrophe and Ebola being everywhere is not really true when you go onto the ground. I worked in the middle of a big Ebola outbreak in Guinea, and outside of the treatment center where there were a lot of sick people and it was catastrophic, life went on, right? You wouldn't know otherwise that things were different. And I say this all because I would hope that we have a bit of humility when we think about these images that come out. I'd hope we'd all have some humility in not pathologizing people who are pushing back against structures that seem foreign to them. And I hope that we're able to recognize that, we just went through 6 years of a pandemic here in the US, where we had people burning masks on the steps of the state capitol in Idaho. We had people refusing a vaccine that clearly saved lives for a whole host of reasons. We had people saying that COVID wasn't real or that it was a government ploy to make money or to kill people or whatever it was. We have heard so many of the same talking points, so much of the same pushback as we're seeing on the ground in Congo, but the imagery of that is different. One is pathologizing and one is seen as patriotism.
Outbreaks like this expose the lack of trust. Is there anything that could be done to close that gap?
Yeah, and obviously, just like the situation here in the US, the desire to build trust is important, but it needs to happen before you need to be trusted. And there's a whole host of reasons why, particularly in Eastern Congo, people have no reason to trust. I have a friend of mine that's worked in the region for 3 decades and has helped stand up and support an NGO there. And he said that in the decades that he's worked there, over the past year has been the only time ever that he wasn't able to go to certain places in Eastern Congo. And that was because he was American and because of such anti-American sentiment after the rapid withdrawal of so much support, particularly from USAID. You also see in Kenya over the past week or so, with the announcement of a potential quarantine facility there, that anti-American sentiment has surged up. People are incredibly angry. And so this is more than just an American or an anti-American thing, but you see that it's going to be impossible to build trust in a response that has to rely on outsiders, either for funding, logistical support, technical expertise. It's going to be tough to build that trust if people see a whole host of reasons, continuing reasons for them not to trust us, particularly international experts. And the way that we build this trust, just like the way we build it here in the aftermath of the pandemic, is we have to have conversations that are focused on understanding and finding ways to collaborate and work together, as opposed to finding ways to kind of bully through or just push through the ideas that we think are best and trying to get community support and sign-on for those things. That cannot be a proxy either here in the US, but quite frankly, during any Ebola outbreak, that biomedical approach cannot be a proxy for that much harder work that is slow and is painful and takes more and different resources, but is absolutely necessary if we want to get communities on board with the approach that we actually need to end outbreaks.
And how do we do that? How do we end this outbreak?
It's a great question. Part of it is the stuff and the staff. We need more people. We need the cavalry to come in, but we need them on their horses. And so we need testing, we need treatments, we need all of those things, right? We do need the biomedical tools. But what's going to be most important is understanding how people on the ground understand disease. It's not that they don't know that Ebola is real. They understand Ebola is real. The problem is that we, as outsiders, often have a hard time understanding that folks on the ground understand that this is real and this is deadly, but have other things in their lives that make it feel like that risk is worth it. The example that I often give is that, I remember when I was working as an epidemiologist in 2015 in Guinea, there was a story about a family who had dressed their loved one up, Weekend at Bernie style. He had died of Ebola, and put him on public transit and really transported him across the country. And that was not because they were ignorant or didn't know that this was dangerous to themselves, but they knew that if they did not bury their father in his ancestral village, he would haunt them for the rest of their lives. It would bring havoc into their community. And not doing this, not taking all, steps to bring their loved one back to where he was born and where he lived and where he identified, not doing that seemed way more dangerous than any risk of Ebola.
You mentioned Kenya, and there's been discussion of sending people suspected Ebola to Kenya instead of to the United States, which is, I think, what was done in previous outbreaks. As someone who is risking their life to go and save people, how does that square with this whole experience?
I think there's a whole host of issues with this Kenya facility. I think let's start with face value. I don't think it's unreasonable to say that we should have some place in the region where we're able to coordinate and have a nerve center, particularly one outside of, the hot heat of the red zone. I don't think that part is crazy by any means. The things that concern me here are manyfold. Most importantly, you're right. We've shown that in previous outbreaks, we have been able to safely bring people back to the U.S. to get high quality care, without which, quite frankly, many of them would have died. We have a whole set of hospitals around the United States. If folks that know about them, we have, through a national special pathogens system, through something called NETEC, and through what are called RESPECTs. We have 13 different hospitals around the U.S. that are capable of managing high consequence pathogens exactly like Ebola, that prepare every single day, that nerd out at meetings that I've been to where they talk about, sending specific aliquots and how they do this and how they, work on monoclonals. Like, these are people that are truly committed to this cause. And I'm worried that this system is not going to be relied upon because we're going to try to set up something temporary and undoubtedly inferior on an Air Force base in Kenya. And I think, quite frankly, for me, the biggest problem with this facility is the moral failure of what it represents. And over the last year, the U.S. has abdicated its role as a global health leader. And I worry what it means when we abdicate our responsibility to our own and our own citizens. There has been reporting, and I can confirm after speaking with many folks, that the reason Peter Stafford was not brought back to the U.S., the American that was being treated for Ebola in Germany, and that others were not brought back to the U.S., including his family, was because this was a White House directive. And the goal was to have no Ebola here in the United States. And I understand how that could be appealing. I understand how that can be attractive to folks that don't want Ebola here. But we expend so many of our resources in the military for the commitment of no man left behind. Recently, there was, one of our military members who had gone down behind enemy lines in Iran, and we sent an incredible force of people at great expense to go and bring this person back home. We need to think about the commitment that American providers and people showing up are making in a similar way. Because if we don't tackle this outbreak where it's at, where it's growing, we can try to build the fortress of our dreams as big as we want, with walls as tall and as thick and as deep as we can possibly imagine. And that will not protect us. That will not protect us from a growing outbreak. Ebola is the most humbling virus. I know this personally. We've known this from previous outbreaks. The only way to manage this is not with threats. It's not with closing ourselves off, but it's directly attacking it where it's spreading, building trust, making sure those tools work. And if we're not able to do that, I think, unfortunately, we will be humbled yet again here soon.
Is there any hope here? 10 years ago, it was devastating. We must have learned a lot of lessons. Is there anything we can take from that experience, or that we are taking from that experience as we go forward?
Well, let me preface this by saying I teach a class called Lessons Unlearned in Humanitarian Response in Public Health, so you can understand a bit of my perspective. That being said, I am an eternal optimist, and I think that global public health and humanitarian assistance is incredibly essential, despite its warts and all. A decade ago, one of the big issues was that WHO and the international community was slow to respond. Even though there was a delay in detection in this outbreak, WHO and Africa CDC and even the US have stepped up. And so I think that lesson has been learned. A decade ago in the West Africa outbreak, it took forever to get clinical trials underway, like a really long time. Some trials were starting a year or longer in. Since then, we've learned that we need to have trials and protocols and agreements ready to go. And so we're a few weeks into this outbreak, and trials are stepping up, and we know that there are candidates and there are things that we're going to be able to roll out. And so from the speed of our ability to do trials and get the tools that we need, vaccines and other treatments, that is certainly a lesson learned. And we've also seen, at least in the first few weeks of this outbreak, that the coordination between WHO, the Africa CDC, the governments of Congo and Uganda has, by all appearances, been strong. And I think part of that is this recognition that over the last year, countries, including the U.S., but again, not just the U.S., have pulled back humanitarian assistance and support and have sent the message that maybe you guys are all on this on your own. And so I think countries are recognizing that, and they're stepping up in a way that I think is much more sustainable, probably going to be much stronger, and hopefully will be a show of force here in terms of how they can manage this. I will say, in terms of things that we haven't learned, one of the biggest things that I'm worried about now may not seem like a massive priority, but is something that I worry in 2 to 3 years we may have realized that we missed the boat on. And that is ensuring that any kind of medical countermeasures that come from this outbreak are equitably accessible to people who need them going forward. We have shown that a decade ago and really over the last 6 or 7 years, when we've created vaccines and treatments for Ebola Zaire, the different species of Ebola, that getting those to be accessible broadly to the folks that need them, particularly across West, Central, East Africa, where Ebola outbreaks occur, has been a challenge. Thankfully, that there is this stockpile, this ICG, Gavi, and others help set this up, where for Ebola vaccines for Zaire, we have like 500,000 of these ready to go at a moment's notice once an outbreak is deployed. But we have not seen the same development for Ebola treatments, of which many exist, 2 exist, FDA approved. Those treatments exist, one of which was directly derived from the blood of a Congolese survivor of Ebola. And they were trialed in a palm trial in Congo a few years back, and that's how they got FDA approval. But despite that, only about 1/3 of patients with Ebola, including many Ebola patients in Congo, were actually able to access either of these treatments in recent outbreaks. Because these treatments are owned primarily by the U.S., sit in our strategic national stockpile, and are not readily accessible when outbreaks occur. And I worry that unless we put in place the mechanisms immediately, as another trial is really standing up, we may be in a similar scenario with something like MapBio's MVP 134, which shows a good potential promise here, not just for the Bundibugyo strain, but as a pan-Ebola treatment for Zaire, for Sudan, and Bundibugyo. And it would be an incredible shame if we didn't learn the lesson of the last decade, which is that if we don't ensure access to these medical countermeasures before trials take place, then countries and the individuals impacted may not have the leverage in the aftermath to be able to ensure that they have access to them when they need them the most.
Craig Spencer, thanks so much for sharing your unique perspective.
Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.